Good afternoon, everyone. Welcome to our lunchtime webinar, the arch enemy, Flatfoot. Okay, I'm Dr. Sian, and I'm the head of foot and ankle surgery here at Singapore General Hospital, and it's my pleasure to host this webinar today. Now, flatfoot is a very common condition that we see in both children and adults with varying degrees of severity. While the majority do not have any significant symptoms, it can sometimes be associated with several other foot conditions and can cause progressive pain and disability if neglected. So over the years in SGH, we have successfully treated a large number of patients with flatfoot with a combination of non-surgical and surgical methods. So as such, we would like to share our experience, and we've prepared an educational program today with 3 knowledgeable speakers who will share their expertise on flatfoot with everyone. And then this will be followed by a Q&A session. Right, so moving on, our first speaker today is Dr. Kizher Buhary. Now, Dr. Kizher is a bioengineer who has turned orthopedic surgeon in our foot and ankle service. He's very passionate about foot and ankle biomechanics research, and he'll be speaking on the foot biomechanics, what is flatfoot and how it can affect you. So without further ado, Dr. Kizher, please.
Hello, hi, good afternoon, everyone. Thank you for joining us today. Can you all see my slides?
Yes, can.
Yeah, all right. Just give me a minute. Hi, good afternoon. I'm Dr. Kizher. I'm one of the orthopedic surgeons with the foot and ankle team. And today we're going to talk about flat feet. It's also known as pes planus. So pes means foot and planus means flat. So by definition, pes planus means it's a collapse of the medial longitudinal arch with the entire sole of the foot coming into complete or near contact with the ground. So if you look at the photograph, the picture, you can see that the top picture shows how the flat foot is, and then the bottom one shows how the normal foot is. If you look at the photo on the left, you can see that the alignment of the hind foot, so when you're looking at the foot from behind, you can see that it isn't straight anymore. And this can give rise to what we call a hind foot valgus, which results in the worsening of the flat foot. So the medial border of the foot is abnormally in contact with the floor during weight bearing. So these are clinical photographs where you can see this. There is low or absent medial longitudinal arch. That means the inner surface of your foot. There is no arch that we typically would see once you weight bear. And when associated with deformities of the hind, mid, and forefoot, it's also called pes planovalgus. So this is just a technical term that we call to describe it. What basically is going on is that the medial side of the foot tends to be overloaded. So when you're looking at these clinical photographs, the first thing we notice is the one on the right. We see that there is no arch and the arch is collapsed. And also when you're looking at the foot from behind, which we often do with our patients, we can see that the toes are visible on the outer side. So we call this a too many toes sign. And when we look at the hind foot alignment, it's no longer straight. We can see that it is more bent, and we call this valgus. So if I were to look at the footprint and to compare a normal foot and that with one with pes planus or flat feet, you can see that it is the footprint, the surface area of the footprint is much larger in a patient who is flat-footed. In terms of etiology, it is one of the most common orthopedic deformities that we see, and it can affect 15 to 20% of adults. And most of the time, these patients are asymptomatic. That means they have flat feet, but it doesn't bother them, and they don't come and seek any medical attention. Of this, 2/3 of them have flexible flat feet. So this is a very clear distinction. I'll go into the details of what is flexible and what's rigid, but most of them have flexible flat feet. And at the same time, they may have contracted tendoachilles. That means their TA tendon can be very tight. Their calf muscles are very, very tight. And this is commonly associated with flexible pes planus. Rigid flat foot is another subgroup, and this one, the most common cause is with a condition called tarsal coalition. I'll go into the details of it later as well. So what do the patients typically complain of? Mainly, they complain of the abnormal appearance of their foot. They have difficulty with their shoe wear and also with walking and running, and pain along the arch of the foot, with pain aggravated with any vigorous activities such as sports, running, and especially when they're running on uneven ground. So in children, the medial longitudinal arch normally develops during the first decade of life. So therefore, flat feet is very common in infants and common in children and should be rare in adults. In fact, flat foot in an infant is actually a fat foot, as an excessive amount of fat obscures the arches. So when we're doing our pediatric rotations, we have a lot of parents who come in who are worried that their child is flat-footed. And 95 to 99% of the time, it's just reassurance that they will outgrow this and the arch will form as the patient, as the child gets older. So there's really nothing to be alarmed about. So the bones of the foot form the longitudinal and the transverse arch. And the inner arch, which is the medial longitudinal arch, which we are concerned about with flat foot, it's formed by a few bones: the calcaneus, the talus, the navicular bone, the cuneiform, the medial cuneiform, as well as the first metatarsal bone, which forms the arch. And the talus forms the keystone of this arch configuration. So any abnormality with this anatomy can also give rise to being flat-footed. Why do we need an arch? What's the big deal? So that's a question that we all tend to ask, you know. So the arch supports the body weight in the upright posture. So it's remember to understand that the arch is formed by not just the bones, but the soft tissue, the ligaments, the muscles, the tendons. All of them play a very important role in creating the arch and maintaining of the arch. So it acts as a lever to propel the body forwards when walking, running, and jumping. It acts as a shock absorber. And the concavity of the arches protects the soft tissues of the sole against pressure. Because you can imagine, otherwise, the amount of pressure over the medial side of the foot increases, and this can give rise to callosities and pain. So when we're classifying pes planus, we divide broadly into two groups. Is it flexible or is it rigid? So the flexible one is the most common, and of which physiologic is the most common, and this is due to the ligamentous laxity. That means that in children, they are typically a lot more loose and lax compared to the adults, and this is very common in the first decade. Some patients also have a very hypermobile flat foot. That means they have excessive ligamentous laxity, and this can be, it can run in families, it can be in patients who have Down syndrome and Marfan syndrome. And the other group are those who have bony abnormalities. So, for example, you don't need to know the details, hyperplasia of the sustentaculum, which is tali, which is part of the calcaneus, or if the calcaneus, which is the heel bone, is not properly formed. Obesity can also give rise to flexible flat feet. When you're looking at the rigid type, this can be a little bit more tricky. So there you have the congenital group, which they have what we call tarsal coalition, which is abnormal formation of bone or fibrous tissue. Vertical talus, which means the talus, remember, which forms the keystone of the arch, is abnormally shaped. And it also can be acquired when you're having any inflammatory conditions, so rheumatoid arthritis, gout, Charcot foot, which is where you have loss of protective sense in your foot, or in traumatic cases as well. And also another group here is those children who had club foot, who grow up to develop this particular type of deformity. So in terms of flexible pes planus, typically they present to us in their adolescence, in their teens, and it's very common. We do see this in the army boys as well. Usually bilateral and asymptomatic, and they typically tend to have a family history of flat feet, and hypermobility is common. The symptoms they normally present with are pain, discomfort, some describe as a burning sensation and fatigue on activity and prolonged standing, and some cramping at night. And the pain is typically felt over the medial side of the foot. So when we examine them, we make them stand up, and then on weight bearing, we look at the patient from front, from the side, and from the back. And we typically see that the arch collapses when they stand. And then we get them to tiptoe. And in flexible pes planus, the deformity corrects itself on tiptoe standing. So if you look at the clinical photograph on the bottom, you can see that as the patient tiptoes, the arch tends to reform. And another test we do is the Jack's test, that the arch can be restored by dorsiflexing. That means flexing up of the big toe, which can be seen in the clinical photograph on the bottom right. We also look at the tightness of the tendo-Achilles tendon. And typically, these patients do have a tight Achilles tendon. And we assess this by dorsiflexing the ankle and then bending the knee and dorsiflexing again to assess the gastrocnemius muscle tightness. Most of these patients also tend to have what we call generalized ligamentous laxity. And we do some special tests in order to measure this. It's called a Baton score. So the clinical photograph on the right bottom shows what are the different components of this test that we would use in order to assess how lax these patients are. And we would document this down. So when we're looking at rigid pes planus, this is the other subgroup. The difference here is that they cannot be passively manipulated without causing any pain. That means the feet are flat, regardless of weight bearing or the position. And when we get them to tiptoe, the arch does not reform, nor does it reform when we dorsiflex the big toe. That means we lift up the big toe, the arch doesn't reform. And pain is usually the prominent symptom. The commonest causes are tarsal coalition and vertical talus. So if you look at the clinical photograph, you can see that on the right side, the patient is tiptoeing, and at this time, the arch doesn't reform, nor does the hindfoot valgus correct itself. That means the alignment of the hindfoot from the back doesn't tend to straighten up like how it happens on the left side. So when we're talking about what tarsal coalition is, this is the commonest cause of rigid pes planus. And in these patients, they tend to form a thin or thick bar, which is either composed of bone, cartilage, or fibrous tissue that connects the tarsal bone. And it has a very irritative focus, and which can cause painful spasms of the peroneal muscles. And it's impossible for the patient to walk on the lateral border of the foot due to the limited inversion that they can achieve. And as a result of this, can result in secondary degenerative arthritis as well. Some of the symptoms, they can be very vague with dorsolateral foot pain around the sinus tarsi, difficulty in walking on uneven surfaces, foot fatigue, and may even have a painful limb. They tend to have a positive family history, and half of the time it can be bilateral. So calcaneonavicular, these are the bones of your hind foot, and the talocalcanean coalitions between the talus and the calcaneus are the most common that we would see. Another group is called vertical talus. This is a congenital rigid flat foot. And if you look at the clinical photograph on the bottom left, they tend to have this typical appearance of a rocker bottom foot. And these patients typically present with pain at adolescence. They tend to have a waddling gait, and the deformity is quite rigid. So we tend to do x-rays, and on the x-rays, we can see that the talus, the bone that forms the keystone of the arch, is abnormally oriented. So what are the investigations that we do? So we always get x-rays done for our patients, and they're always weight-bearing x-rays of the foot, AP, anterior posterior, as well as the lateral x-rays. And there are certain measurements that we do in order to assess to what degree is this pes planus. So the more important one is the lateral x-ray, where we look at how the arch has collapsed. And there are different angles that we measure, including one which is called the Meary's angle, and another which is the calcaneal pitch, which tends to indicate pes planus. At the same time, we also look at the hind foot. That means the alignment of the foot from behind, and see whether it's valgus or neutral. And in pes planus, most of the time we see the hind foot valgus. What are the other special imaging? We don't do this for all patients, but sometimes if we suspect tarsal coalition, then we would do a CT scan, or if you're looking for any congenital abnormalities. And also the CT scans are very useful in helping us for operative planning, especially if they need multiple surgeries involving multiple bones. We also tend to do MRIs, and this is more when we suspect any tendon issues that can give rise to the pes planus, or there's any soft tissue components that we want to assess. MRIs give us a better picture of this. So adult onset acquired pes planus, this is something that we commonly see. And the main reason for this is due to the posterior tibial tendon dysfunction. It is the most common cause of adult onset acquired flat foot. So that means these patients have a normal arch during their teens and in their early adulthood. And once they get older, they tend to see that the arch is collapsing. And I'm sure there's a large group who tends to see this. And this is the commonest group that we would see in our clinic amongst adults. Chronic tenosynovitis, that means inflammation of the tendon, loss of continuity, and loss of normal anatomical relationships of the tendon insertion, results in the inability of the tendon to plantar flex and invert the foot. So this is the function of the posterior tibial tendon. We have many tendons in our foot, but this tendon tends to play an important role in plantar flexing, that means putting your foot down, and inverting, turning your foot in. And this results in the loss of stabilization of the medial arch. And the components of the deformity is that you have a hind foot, which is in valgus, that means it's no longer straight, it's curved. The midfoot is in abduction, that means it's rotated out, and the forefoot is turned in. So it tends to worsen the flat foot deformity that is seen. It tends to be more common in women and often present in the 6th decade. So they're typically in their 60s. There are some risk factors, including obesity, diabetes, increased age, use of steroids, and also inflammatory disorders such as gout or with rheumatoid arthritis. So what are the clinical features that we would see? Primarily, they complain of pain initially medially, but later on the lateral side of their foot. The foot and ankle fatigue after only doing limited activities. They just walk a few steps and then they feel that they're having this pain, and gradual or acute onset deformity of the foot. The signs that we see is that there's a flat foot deformity, absence of the heel varus on toe raise. There's an altered gait pattern, that means they walk in an abnormal manner. And then there is also swelling around where the tendon is. So these are broadly classified. This was developed by Johnson and Strom in 1989. And the different stages depends on to what extent the deformity is and what is the cause of it. For example, if you're having inflammation of the tendon, we stage this as stage 1, they're still able to tiptoe and then the arch tends to reform. And then as the stages progress, it becomes more rigid. So from flexible, it becomes more rigid. And your management plan also tends to vary based on what the stages are. So as an orthopedic surgeon who sees this patient, it's very important for us to classify the patients who come with pes planus based on what we think the stages are. And then our management, which will be discussed later, depends on that. So the treatment depends on the stages. Usually stage 1, we would treat them with rest, give them some non-steroidals such as acoxia, for example. We sometimes do opt for physiotherapy, injections not so much. And also we give them what we call orthotics, which Gordon, my colleague, would talk to you more about to help with this at stage 1. At stage 2, again, there's physiotherapy, orthotic devices, and then there are other surgeries that can be done as well. And then as we move on to the higher stages, stage 4, from the orthopedic standpoint, we would need a bit more of a complex surgery. And this is where we would need special imaging such as CT scans and MRIs before we plan what needs to be done. So in summary, pes planus is a presentation of various pathologies in the foot that lead to an alteration of the medial longitudinal arch. So the arch collapses. It's important to distinguish if they're flexible or rigid, and patients may typically present with pain, deformity, or both. Treatment varies from physiotherapy, orthotics to complex surgical procedures, depending on how severe the deformity is, and as I mentioned, the stage in which the patients present to us. So my colleagues will continue on and talk about the different types of orthotics, as well as the different surgeries that we tend to do here at SGH. Thank you.
Okay, thank you, Kizher. That was a very detailed talk. And moving on, our next speaker is Mr. Gordon Williams. Now, Gordon is a principal podiatrist with our podiatry department in SGH, where he has worked as the lead musculoskeletal podiatrist over the past 3.5 years. So he hails from New Zealand and is very experienced, having worked in the UK, New Zealand, and now in Singapore. And he has a very strong interest in biomechanics and orthotic therapy. Now, Gordon will be sharing his vast experience in orthotics for Flatfoot, right, including the latest developments and technologies such as 3D printed custom orthotics. Gordon, if you please.
Yeah, hi everybody. Thank you, Kizher, for that great presentation. It was really thorough, and I actually learned one or two things, or reinforced one or two things again. Okay, so yeah, my name is Gordon, and yeah, I've worked at SGH for a few years now. Today, in my short presentation, I'm going to focus in on the use of footwear and orthotics in managing symptomatic flat feet. Okay, so that is people who present with pain in the feet or dysfunction relating to their flat feet. Okay, it's important to note that many people with flat feet don't have significant problems or need treatment. You know, up until the age of 6 years, it's quite normal and expected to see a flat foot or a flattish foot. And at that age, the majority of people will develop this increased arch posture, but approximately 15 to 20% will go on to have various degrees of low arched feet or flatter feet into adulthood. Okay. I'm also going to very briefly touch on the importance of having strong feet if you have flat feet. And I think we already had a question from one of the audience members regarding that, so I will touch on that in a slide further on. Okay, just a quick disclaimer. In this talk, any of the footwear brands and models that I refer to are for educational and illustrative purposes only, and they're in no way an endorsement by either myself or SGH of these products. Right. So I'm going to sort of cover some of the same ground that Kizher did, but I'm probably going to summarize it hugely. So certainly, yes, flexible flat feet, they're the most common type. When you're not standing, you can see the arches, but they tend to disappear when you stand and place weight through the feet. Flexible flat feet is noted during childhood and the teenage years, and it usually affects both feet, and it tends to get worse with age. That's as people get bigger and put on weight, there is more load exerted through the feet. This elongation of the feet on weight bearing causes stretching and increased and prolonged loading of muscles, tendons, and ligaments of the feet, which can give rise to symptoms. So in that diagram there, you can see the lowering of the arch, the angle in the heel will get less, and the foot will actually lengthen. Okay, and it stretches a lot of the structures on the sole of the foot, causing pain. Right, next one is the rigid flat foot, much less common than our flexible. There's minimal arch noted whether you're standing or you're sitting. This often develops or becomes obvious in the teen years, and it tends to get worse with time, tends to give more symptoms with time. Often the feet will get painful and they become stiffer. The symptoms are usually noted sort of through the midfoot area, the heel and the rear foot. but they can affect the legs and the knees too. Okay. Usually affects both feet, but it can be one foot or both. In this photo, we note that the arch of the foot, okay, so this is the person doing a little heel lift test. They're rising up off their heels. And we notice that the arch of the foot doesn't reform and the heel bone doesn't tip inwards when the person rises up off the heels. And this is the opposite of normal. Usually the reverse should happen. All right, then we're moving into our adult acquired flatfoot deformity, sometimes known as posterior tibial tendon dysfunction, or PTTD. This is a progressive, debilitating condition with a complex pathology. One of the hallmarks is collapse of the medial longitudinal arch of the foot, and this continued progressive deformity of the foot and the ankle. Okay, so as marked in the diagram with the white arrows, you see that too many toes sign that Kizher was referring to. Now, this is usually seen in one foot, but can be seen in both. Usually affects females more than males, and upwards from 40 years upwards, usually a bit older than 40. And yeah, known risk factors are overweight, trauma, conditions such as diabetes, etc., ones that Kizher also mentioned. Now with this, the symptoms are usually noted over the medial rear foot and the medial ankle area. There are 4 stages to this. The first and second stage, we normally can look at using in-shoe orthotics. So these are devices that will go inside the shoe. They are hidden away. You will not see that you're using them. Stage 3 and stage 4, it's when you may require larger braces, one called the Ritchie brace, and we'll have a photo of that shortly. The later stages tend to lead to significant changes in our walking gait, and you get what we call an apropulsive walking gait. And this is when there is an inefficient push-off from the foot noted. And usually it will overload tissues and pain will be the result. Right, now I'm going to get into the bulk of my presentation. I'm going to very briefly outline some shoe inserts. Now these can vary from basic wedges through to custom-made 3D printed orthotics. These are going to influence the biomechanics of the feet and the legs as well by changing the forces and the loads through the feet. Now in this image over here, we have a picture of photograph of some prefabricated orthotics. You can see we're looking at this picture, this image from the bottom, from underneath them. And in the left one, or to the right in your picture, you can see the red heel wedge. And what happens here is we try and apply various wedges in various positions of different thicknesses and different densities, and we grind angles into them. Okay, and this is going to change loading through the symptomatic structures in the flat foot. These insoles, we've got many kinds that we use now, many different brands, many different models, and we try and match one up to the person's individual requirements in terms of, like, do they have a wide foot, a narrow foot, are they very heavy, are they lighter, etc. And also these insoles can be heated with a low heat source. So in the clinic, we've got a machine, we put these insoles inside a shoe and we apply heat at a certain temperature for a certain amount of time, and it actually softens the foam. And this is going to help shape it to the person's foot. And this all helps to make it fit better and be more comfortable. Okay, now recent developments in the area of 3D printing technology has made its way into the manufacture of custom-made 3D printed orthotics. The introduction of 3D printed nylon orthotics has allowed for designs of devices that until now just weren't possible with traditional manufacturing methods. So these new ones can be made of what we call variable thickness. So certain parts of the device will be made thinner than other parts. This is going to result in a better fit of the device inside the footwear and also improve tolerance to the orthotics with better outcomes. Being thinner, they also become lighter. Okay, looking at this photo here, at the top we've got an image of some hardware that we use, and this is a device that we use to actually scan the foot. In the image at the bottom right, you can see the application of the scan. It's a painless infrared scan of the feet, and it paints the foot in that white color. It looks like a plaster of Paris foot. And it's this that we then use to send to the laboratory. So this gets sent electronically. So it's very quick. And we will have the device printed and then completed. Various finishings are done there. We put like top covers on the devices. These are like foam pads, and they are either full length all the way past the toes, or they sort of 2/3 length, or they are shorter, just what we call a shell edge. This all leads to quicker manufacturing and turnaround times than our traditional methods. And we've been using, in our department anyway, 3D printed orthotics for, it's coming up to a year now, and we're getting really good results, very well tolerated, and they're also relatively easy for us to adjust. If we have to grind them, it's quite easy, and we can also heat them. So we can use a heat gun and heat up the nylon shell and push it into a different position if required. Okay, so here we've got a couple of images of 3D printed orthotics. The top photo is the view from behind, okay, and the bottom photo is the view from below. Now, as you can see from the orange arrow, so this is placed flat on a desk, and as you can see from that orange arrow, this device is going to exert an upward force, okay, over the medial or the inside of the foot, and this is to support and offload the structures passing through and above this area. It's important to note that the orthotics function is very closely related to the footwear that is being used in. So if you go and put an orthotic like this inside what I would call a bad shoe, then a lot of the effects of the orthotic will be reduced. Okay, so the device and the shoe are going to work synergistically. Okay, this one, it'll often be printed in as to how thick it is. We can make these from 0.5 millimeters. That would be far too thin. It would need reinforcing. On average, they're about 2.5 to 3 millimeters thick. Right, now sometimes in our severe cases, we're talking kind of stage 3, stage 4, sometimes a more substantial brace is required, and this is what we call a Ritchie brace. Now this is going to provide support above the ankle with a custom-made component for the foot. It's got some straps, Velcro straps, that you can draw in, and it makes it nice and snug. It pulls those stirrups against the actual lower leg. It also has a hinge in it. So when you look at that diagram, you'll see a little white dot in the middle of the black. And that is actually a hinge. And it's going to allow normal range of movement in the up and down position, what we call dorsiflexion and plantarflexion, but it's going to strongly restrict side to side movement, okay, inversion and eversion in the rear foot. The downside for these is that they are bulky. You need wider footwear to accommodate this device. So it will make it a bit limiting as to what you can wear. But they certainly are quite effective at reducing symptomatic flat feet. Okay. Okay, now moving on to footwear. In this slide, we've got a fairly traditional running shoe that all of us are going to recognize. When the clinical decision to use orthotic inner soles or for symptomatic flat feet is made, we will usually recommend footwear that has most of these features. So I'm going to quickly just touch on those features. Okay, first of all, we need a wide shoe upper and a wide base. A wide shoe is just going to accommodate any, say, insoles that are put inside, any orthotic inner soles. And having a wide base is just going to give you a more stable platform to work from, a better foundation to stand and walk from. Okay. Second, we're looking at a supportive heel collar and a deep heel counter. Okay, this is going to provide support for the rear foot, help reduce movements. We're looking at heel drop in the other one. Okay, now this is also known as pitch. Okay, and in this diagram, you'll see the two black lines. And this shoe is going to have a pitch or heel drop of about 1 cm. Means it's going to be higher in the heel by 1 cm as opposed to further forward in the forefoot area under the toes. And what this does, it encourages forward movement off the heel and it deloads the tibialis posterior tendon. And this is because a lot of the time with these flat feet, as Kizher mentioned, you often have tight calf muscles accompanying this adult acquired flat foot deformity, and having that extra little heel lift, it just helps push you forward off your heel, gets you moving forward easier. The next one is a firm midsole. So in this diagram where we can see the N of this New Balance shoe, if you drop down from that to the center of that midsole, we want this area to be stiff. Okay. What this does is it has a splinting effect, and this reduces load through our symptomatic areas. It's going to provide portional stability for the foot, and it's also going to help work with that orthotic to get you that best outcome. The last feature I'm going to point out on this image is the toe spring, and this is in the front of the shoe. You can see that curvature of the yellow outer sole as it moves forward up towards the toe box. And what this does, it helps encourage forward movement when you're walking. Okay, it's important to look at the shape of your foot when selecting shoes. You know, some models and brands are going to come in width options. So for example, a narrow for a woman is going to be a AA, that's alpha A. B is Bravo, is a standard width, and then D Delta is going to be a wide option, a wide width for a woman. Okay, now in men, a narrow is going to be a D width, 2E is going to be a wide width, and then your 4E will be wider still. Okay, now not all brands and models are going to come in your width options. Most are going to default to a standard width, but it's good that there are these shoes out there that if we have to say use an orthotic that is quite broad because of the requirement clinically what's needed, or if we have to use one of those Ritchie braces, we have footwear available that will accommodate it and work well with it. Just some very quick practical tips just on correctly sizing our footwear. Obviously, we need to get the right width and the right length. It's best to shop for your shoes at the end of the day, because for most of us, the feet are going to swell slightly when we stand and walk, and you want to fit the shoe to the sort of swollen, bigger foot. You want to have about a thumbnail width, okay, from the longest toe to the end of the shoe. And good shoe retailers, they can measure your feet with a device called a Brannock gauge. Basically, you put your feet onto a machine, they slide these things around and they can read off length and width, and it'll help them find the correct shoe for your foot in terms of fitting. Really important when you're dealing with the flat foot is adjustable uppers. Lacing remains the way to go in terms of securing the shoes onto your feet. And you can use alternate lacing methods to provide better fit. Okay, so if you look at this image of our New Balance shoe here, you can see we've got two available holes. You can lace further up into those holes, and you can do a particular knot called a runner's knot or a lock lace, and that really draws the upper of the shoe around your foot, and it makes it really nice and snug, and it also locks your heel into the back of the shoe. Now, if you have to wear sandals for your flat feet, there are times when you're just unable to wear a closed-in shoe, then you want to go for a type that has supportive straps. And I would say at least 3 or 4 adjustable straps so that you can tighten them to provide good support. And you also want to get a sandal with a good footbed, okay, that has some form to it, a bit of an arch. It mustn't be flat. Some sandals out there have removable footbeds that you can take out and then you can replace with a customized or custom-made orthotic. Right. I'm quite a proponent of foot strengthening. We know that strong and stable feet and legs are certainly desirable for successful movement. And for those with symptomatic flat feet, I would say the stronger you can make that foot, the more you can load it and the more you can do with it without it protesting, without it making pain for you. Now, there are a myriad of foot and leg exercises out there that can be utilized as part of managing flat feet. And it's really a bit beyond the scope of this presentation to take a deep dive into foot and leg strengthening. But these are my top 2 exercises that I would start with. Okay, the number 1 is your short foot exercise, also known as your pen and penny exercise. And that is illustrated here in this top photo. So what you do is you slide a pen, it's a white pen, underneath the arch, and you slide a coin, in this case a penny, underneath the big toe joint. Now what you need to do when you're doing this exercise is to slowly raise your slowly raise your arch and bring it away so that it's not touching the pen, but it's important at all times to maintain contact with that coin under the big toe joint. Our next exercise that we want to be doing is our heel raise. Performing heel raises uses a lot of muscles. It's going to employ the long calf muscle. If you do it with a slightly bent knee, it'll also work your short calf muscle, and it also works other muscles that go from our leg and attach into our feet. You can vary how you do these by, for example, going up on 2 feet and slowly coming back down on 2. You can go up on 2, come down on 1, or you can go up on 1 and come down on 1. But when doing any of these exercises, it's really important that you follow good form, and that's the method of doing the exercise. You want to be doing them slowly and controlled. Normally I say to people, so let's say we're doing your short foot exercise, which is going to work those muscles in the arch of the foot and the tibialis posterior tendon and another muscle on the outside of the leg. You want to rise up slowly to a count of 3. You want to hold it at the top of that exercise for a count of 2. And then you're going to slowly bring it back down once again, counting down 3 seconds. There's a lot of places you can go and view these videos. You can jump on YouTube and just go find a good physiotherapy website or a good podiatry website where they've posted exercises, and you will have videos of these, and it'll really guide you in doing the correct form. Okay, so that brings me to the end of my talk. I hope you all got something out of it, and yeah, we'll look at doing some questions later on. Okay, thanks very much.
Thank you, Gordon. That was very educational. Learned a lot of things. Now we move on to our last talk. Our speaker is Dr. Xiang. Now, Dr. To is an associate consultant orthopedic surgeon in the foot and ankle service, and he's got a lot of personal experience in multiple sports injuries and is very interested in restoring function and quality of life. He'll be sharing on when flat foot may require specialist consultation and how orthopedic surgery can help. Xiang.
Great, okay. Thank you. Thank you everyone for listening so far. And I'm Dr. To, as Prof. Tay mentioned, and I would like to share a bit of what we know. So the question that everyone's been asking is, when should you come see us? So when you see us, there are a few things we want to know, such as the duration of onset of your flat foot, whether it's been there since you were young or if it's a recent onset, which is a little bit more worrisome, how the progression has been, whether it's been stable for years or if you feel that your flat foot has suddenly developed and gotten worse recently. And more importantly, we look at whether there's pain or no pain and whether or not the flat foot limits your function. So those are probably the key reasons you should come by to see us for an assessment. So whenever you come and see us in clinic, we evaluate a few things. Firstly, we look at the tendon function and strength. The commonest cause, as they mentioned previously, will be dysfunction of your posterior tibial tendon. And in the adult population, this is one of the most common causes we see, and we assess to see how severe it is. We also do a tiptoe test, which you can see in the top right-hand corner, to see if you're flexible or fixed. There's an easy way. At the same time, we assess if your joints are flexible or rigid. After they become rigid, there's a chance that the joints become arthritic with excessive wear and pressure, and we also assess for this during the clinic visit. At the same time, we look for abnormal wear patterns of your shoe, because with with abnormal foot shapes. The wear pattern on the shoes are different between patients. So we go on to get x-rays, which are standing. There are many x-rays done in the polyclinics and GP clinics, which are non-weight bearing, and this doesn't as accurately capture the true shape of the foot. As you can see on the top right-hand corner, it's a non-weight bearing x-ray of a patient. The arches seem quite nice and beautiful, but when they stand, the foot flattens out completely. And this is a much more accurate representation of the real function of the foot. Not to worry too much about radiation. We know that each x-ray exposes each patient to a minute amount of radiation, and it's about the same amount of 10 days of background radiation in your daily life. So it's not very significant. You don't have to worry too much about it. We sometimes require more advanced tests for patients which do have symptomatic and severe flat feet. And these include a CT scan, which is a three-dimensional X-ray, which gives us a 3D reconstruction of the foot so that we get a better overview of the deformity. And we also do MRIs and ultrasounds to assess the condition of your soft tissue as well as your tendons, and these have no radiation. So the part that we all don't like to hear and don't like to talk about as patients would be surgery. And these options only come into play when our podiatrists, such as Gordon, have done their jobs, fit you with the best orthotics. We've taught you stretching, we've taught you exercises, and still the pain fails to improve, or you have developed arthritis or worsening deformities, then we'll start to discuss the possibility of operative intervention. And the types of surgeries differ greatly between whether you're young or old, and whether your foot is flexible or rigid, or whether or not you've developed arthritis. So in the easiest cases is when they are children, or when your flat foot is still flexible, we can do smaller procedures, such as lengthening of your Achilles tendon if it's tight. And sometimes, as you see in the photo on the right, we use a minimally invasive screw. It's about a 2 centimeter incision, and we insert this screw under X-ray guidance. It's about a 20-30 minute procedure, and that helps to correct some of the flexible flat foot cases quite effectively. The next stage would be adults who have a flexible flat foot. As mentioned, it's often due to tendon dysfunction of the posterior tibial tendon, and we will assess the tendon clinically as well as with MRIs and X-rays to decide if you require any tendon cleaning or repair. Sometimes we do a tendon transfer or reconstruction if it's completely destroyed or damaged, and we still do a lengthening of the Achilles tendon. So I want to just quickly show you guys a video of how we perform a tendon reconstruction. Give me 1 second to let it load.
The Arthrex internal brace spring ligament augmentation repair is a surgery for people who have flat foot due to weakness or rupture of the spring ligament or posterior tibial tendon. Spring ligament is the connecting tissue located under the foot that connects the calcaneus and navicular bone. This ligament is often repaired in people that have a condition called flat foot. It is when the arch of the foot collapses, coming into contact with the ground. The repair begins with the surgeon making a cut on the side of the ankle where the calcaneus, navicular bone, and medial cuneiform are located. Next, the surgeon will create a bone tunnel by drilling into the sustentaculum tali of the calcaneus using a guide wire and drill guide. The bone tunnel is made in the calcaneus to prepare for a swivel lock suture anchor loaded with fiber tape. The swivel lock anchor is screwed into place. Next, the FDL tendon, also known as flexor digitorum longus, located on the medial side of the leg, is identified, cut, and then tagged with a fiber loop stitching technique. A bone tunnel is made in the navicular to prepare for an additional swivel lock anchor. The ankle structures are tensioned and fixed into place by taking one part of the fiber tape and passing it from top to bottom with a suture passing wire. Then, take the other part of the fiber tape with the sutures from the FDL tendon and passing it from bottom to top. The surgeon then holds it in place by inserting the swivel lock from bottom to top. The remaining sutures are cut. The supporting structures of the arch of the foot are now repaired and held together with the internal brace, causing the arch of the foot to be restored.
Great, thank you for your attention. So I hope that gives a bit of insight about what we do. It looks a lot easier than it actually is, but that is the gist of it. So the last stage, which is the one we want to avoid most, would be those feet which have become stiff or arthritic. And then we need a lot more drastic measures, such as bony procedures. We cut the bone and reshape them into the right alignment. And the last of the last resort would be what we call a fusion, where we join the joints together in order to hold the foot in a more adequate shape for more stable weight bearing and walking. So when should you see us? Generally, the earlier is better. As I've shown you, in the earlier stages or in the flexible stage, the measures tend to be more less invasive and to have better outcomes. They tend to be smaller surgeries and quicker surgeries with a faster recovery time. So if you're in doubt and you're in pain, it'll be better to come for an assessment earlier, especially if you have flat feet that cause pain, limitations in your function. They cause you frequent injuries. You find that you're falling over yourself, your feet rotate unnecessarily, or you have issues with walking and balance, or especially if they affect only one foot. So the future that we are aiming towards and already starting to work with would be 3D printing. We start to use it in the podiatry service for insoles and also in customization for implants. We've already started to use this in some of our foot and ankle surgeries, where we're starting to adapt it to flat feet. So 3D printed implants will allow us to streamline the surgical process, because this helps to reduce the amount of time taken overall to perform the surgeries. And of course, this leads to improved patient outcomes with quicker recovery times, reduced discomfort, and better quality of life. Okay, thank you for all your time and attention.
Hey, thank you. Thanks, Xiang. Okay, thanks for that overview of what kind of surgery we can do for patients with bad flat feet. Now, we have come to the end of the talks, and I want to thank everybody for their excellent presentations. And now we can move on to the Q&A session. So we've already started answering some of the questions on the Q&A with the typing some replies, but we can go on to answer some of the more several of the questions live as well. So I'll just get things started. I think that there are let's see, I think Gordon has got a question here. Is that right?
We can start with you first.
Okay, so a number of people have asked whether early intervention for flat feet can help progression or development of secondary arthritis, because all types of flat feet have been reported to progress. And the truth is that if the flat feet are completely asymptomatic, as some of our other speakers have alluded to, many of them don't need any treatment at all, because a lot of people go through an entire life with flexible flat feet and have no symptoms at all. However, if you start having symptoms like pain, fatigue, aching in your feet or ankles because of this, then treatment is necessary, because at that point, which means that if you're having symptoms, it means that the injuries are starting to occur, degeneration is building up, and problems are starting. And if this is neglected at that point, then yes, it will progress. But a completely asymptomatic flat foot, not all of them progress to having problems. So, if we're too aggressive in treating all of them, then it'll lead to a lot of over treatment and unnecessary kind of costs and time and expense of everyone going for all this treatment. So I would suggest that if you have symptoms, then come early to seek treatment or whatever type of treatment is necessary. But if not, then not everybody needs this.
Okay. So just which question? So AAF is irreversible. So I think if I can answer this question by saying we want to try and avoid getting to stage 3 and stage 4. So that's why it's really important that if you start noticing either on yourself or family member or something that you get this flatter foot, and they're starting to give you pain on the inside of the sort of ankle area, get it seen to sooner rather than later. There's quite a few that we get through here that people have just sort of neglected. And then once it becomes a stage 4, yes, that's going to require probably surgery, even stage 3 sometimes. So I guess to answer this question, catch it early. Don't let it get to those higher stages. Okay. The other question. I'll just get to, can orthotics affect functions of feet? And yes, definitely. So orthotics are used to change, they've got quite a lot of effects, but one of the things that they do is they will change loading through certain tissues. Okay, so, and we know this, these are tests that are done in laboratory, tests, as well as clinical studies, show that yes, the use of various orthotic wedges, insoles, will change load. It's going to change function. It also changes timing to which tissue it has a load applied to it. And they are very safe therapies. It cannot fix everything, but yes, it will change foot function. And in the symptomatic flat foot, it usually will give you a good outcome. Okay. All right, and then just our final one is, do 3D printed orthotics last as long as normal orthotics? And is weight a limiting factor for 3D printed orthotics? So yes, they can last as long as a sort of a standard orthotic. The actual shell that they're made out of, a nylon shell, if you make that thicker, it's going to last longer. It's going to be stronger. But of course, it is going to get a little bit thicker. It's not going to fit as well. And it's going to be a little bit heavier. So sometimes what we do is we will, if we say have a heavier patient, we will thicken certain parts of the orthotic, vulnerable parts of that orthotic that can withstand the greater load, but it's not going to make it too bulky. It's not going to make it too heavy. Of course, certain parts of the inner sole of the orthotic, the top cover, it's a foam layer that gets laid over the top. That sometimes will need replacing. We can sometimes have that removed and sent away to the laboratory, and they can put a new one. They can reline it, so you sometimes don't have to redesign and rebuild it right from scratch. Okay, thank you.
Hi, so good question. It's a very common question we see in the clinic. So the two things that correlate very strongly with flat feet would be tight calf muscles as well as bunions. Tight calf muscles kind of potentiate the flat foot because it causes undue pressure on abnormal areas of the foot. So as part of our management in the start, conservatively, we always advise patients with tight calves to stretch them as well as to get insoles at the same time to see how their symptoms improve. So yes, they do tend to get tight muscles, and the tight muscles also potentiate the problem. So it's quite a vicious cycle that we try and break. Is there a next question? And yes, flat foot does correlate to plantar fasciitis, because when you have a flattened arch, the plantar fascia is poorly supportive of your arches, and this causes undue pressure on the plantar fascia, which correlates with a higher incidence of patients having pain in the plantar fascia attachments. So this is not so easy to answer because there are a whole variety of procedures that we do to try to help with flat foot. In general, the earlier procedures, like I mentioned, the minimally invasive screw that we use for children and for flat feet, they recover very quickly. We start them walking in the day 1 or day 2, and the wounds take 1 to 2 weeks to heal. And after that, they're more or less back to normal activities within weeks. However, as we wait longer and longer and the condition gets more and more severe, the procedures tend to be bigger and bigger and require longer and longer recovery times. So things like the triple fusion for very severe deformities with arthritis, the patient is off the feet for 6 to 8 weeks at least, sometimes up to 3 months. So as we said it's best to see us early to intervene when we can and with smaller surgeries. Thank you. And yeah, this is a very common question. So I think 4 or 5 people have asked it. Yes, so the flat foot does cause pronation of the foot. There's overpronation and a lot of pressure on the first big toe. And this makes the deformity of the big toe even worse. So when we see patients with bunions, which we often do, we always assess them for flat feet. And if the flat foot is severe enough, we try to correct them in the same seating to prevent the recurrence of the bunion. And it is difficult to correct the bunion in itself. So wide shoes help. Some people use toe spacers. This provides temporary relief, but we know that bunions do tend to progress with time, even if you use spacers. So if they start to have pain, it will be better to come and see us for an opinion. We will often try changes in footwear, calf stretching to see if it helps. And if it doesn't, then we will consider surgical options.
Yeah. Okay, so we talked about when flat foot happens due to whatever causes we're losing weight, referred it back. So obesity is not doesn't directly cause flat foot, but of course the increasing weight and load on the foot for whatever reason can cause the symptoms of the flat foot to become worse. So when you overload the flat foot because of the ligaments and tendons involved in supporting the arch are overloaded, then certainly there'll be more pain or more symptoms. So losing weight is a good way to reduce the symptoms if you already have a symptomatic flat foot. However, as most of the time, if you have a flat foot, losing weight will not cause the arch to come back. I think as as Gordon has alluded to earlier, most of the time the cause of the flat foot is not reversible, and you can't make the arch come back. But we can control the symptoms and reduce the amount of load in a patient who has already got symptomatic flat foot. Yeah. Any other questions? Okay.
Yeah. So got a question here. Purpose for shoes having both ends with rocker action design. And so what that does, it helps encourage movement from your heel through to your toe. So that curvature is just a way of assisting movement forward, okay, what we call the sagittal plane. But it's important to note that not everyone responds equally to that rocker action. We just, what we call responders, we just get better responders. But for most people, they're going to find that it's going to help them move forward, okay. Just in some elderly patients with those, you've got to be a little bit careful because when they take a bit of getting used to, you've got to make sure that your balance is good before you use it in elderly patients. Got another question. If wearing orthotics causes pain, does that mean it's not suitable? Do I continue to wear them or change to other sets? Yeah, so usually an orthotic should not cause pain. You might have, like say, initial discomfort when you first start using them because some muscles are going to work harder than others. But usually that will last sort of anything from days to maybe a week or 2 at most, but you shouldn't have ongoing pain. If you do and you got them from a podiatrist, then go back and make an appointment and they can adjust those for you to make them comfortable. Okay. If the pain is very, very high, then don't continue using them. Just take them out, put them to the side, and then see your podiatrist.
Hi, so you're right. In theory, when we make cuts or drills on the bone, they do become a little bit more fragile, which is why we protect the patient after surgery. And it depends on the type of surgery we do. If we make smaller cuts, we rest them for a shorter period of time. But generally, after 6 to 8 weeks, the bone is healed and stable, and any activities that you once did are free for you to do. So our aim is to get you back to your normal activities. So after an adequate period of recovery, we're more than happy for you to go back to full activities and sports, no problems. So for foot pain with accessory navicular bones, it's quite a common condition that we see along with flat feet. So we often do an MRI to see where exactly and how big the accessory navicular bone is. We always try conservative measures first. We give you insoles, we teach you stretching to see if it helps. If it continues to be pain persistently and the MRI shows inflammation in the area, we'll then discuss with you whether removal is required. We often have to do a tendon procedure at the same time because that's where one of your important tendons attaches. Thank you. Any other questions?
Yeah, so there's this question of whether rigid flat feet does come with age, if you have a flexible flat foot at middle age. And short answer is that if your flat feet in middle age are not symptomatic, there's no pain, there's no problems, then it's not always that it will progress to rigid flat foot. So rigid flat foot is a continuum of the adult acquired flat foot, which is a degenerative condition. So if you have degenerative flat feet, then yes, eventually it might progress to the rigid flat foot with arthritis. So if you have flexible flat feet that are having pain already and having problems, then we should get it sorted and treated early to prevent the progression to rigid flat foot. Because when you get to rigid flat foot, then the treatment options are much more limited and much larger and more complex surgeries may be needed and the recovery will be much slower. So if you do, have at an early stage of the problem, get the appropriate treatment, whether it's orthotics or minimally invasive surgery, then we should get that done early so that you don't progress further on. Yeah. The next question.
I think we went through this already. Are there any other questions?
There's a question on whether flat foot can result in knee pain. That's a very interesting question, and the answer is that sometimes it can be, because when you already have some problem, degeneration in the knee, such as if you have arthritis of the knee, then a flat foot can actually make the problem worse or feel worse because of it alters the way you walk. So sometimes when you put in an orthotic to help to adjust the sole of the foot and the loading, it can improve the knee pain. So that is one of the potential treatment options for people with knee arthritis, actually.
Okay, I think these are the few questions that you guys pull out to answer live. So there are no more other questions to answer live.
Okay, all right, great. I think we are have come to the end of the session. So yeah, I would like to thank everybody for participating today. Thank the panelists for their time and the effort in making the presentations, and thanks to all the participants who have shown a lot of interest and joined us. So unfortunately, we might not have been able to answer all the questions today, but I hope that everybody took a little bit away from the session. And of course, if you have any further queries or any further concerns about your feet, please feel free to come and see us. Okay, we have a very comprehensive service here in terms of doctors, allied health such as podiatry, physiotherapists who didn't give a talk today, but we work very closely together. So I think it's kind of a one-stop to get everything sorted out at SGH. So thank you, everybody, and thanks also to the patient liaison for helping to organize as well.